Good evening, friends. Your final FMG exam is coming in December. Good evening. Good evening, everyone. Let us discuss just as a final touch. You have already prepared everything. Okay. Let us discuss 25 most important questions. Okay. Expectedly, some question will come in the exam. Okay, from this discussion. Okay. Okay. See this question. The conduction velocity is fastest in which fiber the conduction velocity is fastest. Okay, we have classified the nerve fibers. So conduction velocity here, it is fastest in which fiber? A alpha, A delta, B nerve fiber, C nerve fiber. In which fiber it is fastest? Anyone? You are supposed to know this. Very simple question. In which fiber it is fastest? Yeah, Ravi Sharma is right. It is A alpha nerve fiber. Okay, A alpha. This is the answer. Okay, if we classify the nerve fibers, how do we classify the nerve fibers? So nerve fibers are classified as A, B, C. The A type A nerve fiber is further classified as A alpha, A beta, A gamma, A delta. So how do we classify the nerve fibers? A alpha, A beta, A gamma, A delta. Type B, type C. And this classification is based on the diameter of the nerve fiber and therefore the velocity. More the diameter, more is the velocity. Which fiber has the maximum diameter? Very simple. A alpha. This has the maximum diameter. This has the minimum diameter. So diameter is like this. And therefore which fiber is fastest? A alpha. This is slowest. This is conduction speed. Right? The conduction speed in A alpha may be 70 to 120 meter per second. And in type C fiber, it may be roughly 0.5 to 2 meter per second. This okay? So this is fast fiber A alpha, C is slow fiber. Right? It has the maximum diameter and it has the minimum diameter. Clear? Example also, you can give example of A alpha, proprioception. A alpha will transmit proprioception and type C will transmit what? It will transmit pain and temperature. So type C is for pain and temperature. A alpha may be for proprioception. A alpha is supposed to be the fastest. Right? A alpha fastest, type C is slow. Slowest. Is okay? See this question. The active sites on the actin filament are physically covered by. What's the answer? Active site on the actin filament, they are physically covered by. The answer here is, what is the answer? What is the answer here? Answer here is, what's the answer? Tropomyosin. Answer here is tropomyosin. Just see it. This is myosin fiber and this is the actin, thin filament. These are the Z lines. Okay, again this is the thick filament, myosin filament. Again this is the thin filament. This is right. This is myosin, thick filament. This is thin filament. This entire thing is actually a sarcomere. On this actin filament, we have some active sites. These are the active sites. This is the myosin head. This myosin head will combine with this active site. And so association between actin and myosin will start. It will combine with this and do the contraction. But these active sites on the actin filament, they are covered by tropomyosin like this. Okay, tropomyosin is a helical protein. It is surrounding like this. And all these active sites, they are physically covered by tropomyosin. When this tropomyosin will move aside, then this myosin will be attached to actin and the contraction will start. Why myosin can't combine with actin? Why? Because tropomyosin is there. This is actin, this is myosin, and in the middle we have tropomyosin. There is one more thing, we call it as troponin. 3 type, I, T, C. Troponin I, troponin T, troponin C. This is not a circular type of protein, no, it's a globular protein, intermittently attached. Troponin is not covering the active sites, no. Okay, it's a separate structure. The calcium combines with troponin C. This is the simplest of the thing. Calcium combines with whom? The calcium combines with troponin C. The tropomyosin goes sideways, lateral shift in the tropomyosin, and because of which myosin will now combine with actin and the contraction will start. So active sites are physically covered by, it is physically covered by tropomyosin. This is okay? Okay, this is the answer here. Calcium will combine with the troponin C. If somebody asks you calcium will combine with whom? It will combine with troponin C. Is okay? Okay. Titin is something else. What is titin? This is titin. Myosin connected to Z line. This is an elastic protein. It will give the muscle the elasticity. So this elastic structure is titin. Okay, elastic strength. Right? See this question. Okay. The phase depicted below in the action potential of a nerve fiber can be due to. Okay, this phase is because of what? This phase. This is depolarization, this is repolarization, and this is actually hyperpolarization. So this hyperpolarization is because of what? This hyperpolarization is because of, just see this thing here. This is the action potential. This phase is depolarization. This phase is repolarization. This is overshoot. This is zero potential. This is overshoot. Okay. From minus 70, it may go up to plus 35. This may be roughly zero. So above zero, this is overshoot. Depolarization, repolarization, this is hyperpolarization. Why? The answer is, what is the answer? See the choices here. What is the answer? Closure of sodium channel, slow opening of potassium channel, slow closure of potassium channel, calcium influx. This is because of, this is the answer here. Slow closure of potassium channel, C. Is okay? Hyperpolarization, we can also call it as after hyperpolarization. Okay, Dr. Ravi Sharma. After hyperpolarization is a better term. Hyperpolarization, or you can also call it as after hyperpolarization. Is okay? C is the answer here. This phase is because of sodium influx, sodium entry. This repolarization is because of potassium efflux. The sodium channel opens here. Sodium channel, it will open here. Sodium channel will close somewhat over here. Is okay? Sodium channel will open at the firing level. At firing level, sodium channel will open. So sodium will start entering. Here sodium channel is closed. So sodium entry will stop. So sodium channel opens here, sodium channel closed here. And this sodium entry leads to depolarization. At this time, sodium channel is closed. Simultaneously, at this point, potassium channel will open. Potassium channel will open here. So sodium influx will stop. Potassium efflux will start. So we have the recovery. But this potassium efflux will continue for much more duration of time. Potassium channel closure will take time. Potassium channels will close somewhat over here. So potassium efflux will continue. So this repolarization will not stop. It will continue to repolarize. So why we have this hyperpolarization? Why? Because this potassium efflux continues. Okay, it continues. Potassium channels are very slow to close. Okay, potassium channel is slow to open. I agree. But it is very slow to close. So this continued potassium efflux is responsible for this, you can say, continued recovery. So this phase can be because of the very slow closure of potassium channel. See the choices again. Slow closure of sodium channel? No, sodium channels are not slow to close. Fast opening and fast closure. Slow opening of potassium channel? No. Okay, potassium channels are slow to open. It's not that fast. But okay, that is fine. That is why recovery is delayed. Slow closure of potassium channel, yes, this is the reason. Calcium has nothing to do with that. Is okay? So this hyperpolarization or after hyperpolarization is because of slow closure of potassium channel. right? See the next question, very commonly asked question related to JVP, jugular venous pulse. Wave in JVP, C wave. Actually, the question is C wave. C wave in JVP is because of, okay, in the JVP we have 5 waves, A, C, V, X, Y, okay. It is like this: A, C, X, V, Y. A, C, X, V, Y. These are the 5 waves in JVP. And these 5 waves, they have a cause, okay? They have a cause. Yes, answer, you are correct. Answer is this. B is the answer. What is the cause of this? 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 And what is the cause of this? Very commonly asked question. Even last year such type of question was asked. So this is because of what? This is the explanation. Is okay? I have explained this thing in detail in my classes. Okay, very conceptual thing. I'll explain it again. Just see. Heart is a 4-chamber structure. JVP means pressure of the right atrium. In the right atrium we have, this is inferior vena cava, superior vena cava. Pressure of the right atrium will go back. There is no valve here. And this pressure will go back and that will be reflected in jugular vein. So pressure changes in the right atrium, that is actually reflected in JVP. So what are the pressure changes here? Number 1, when this atrium contracts, pressure here increased. This is A wave. So A wave here is because of the atrial contraction. Is okay? Atrial contraction. Now after atrial contraction, this chamber will contract. Okay, first isovolumic, then ejection. When this chamber will contract, this valve will bulge. This tricuspid valve will bulge. So pressure in the right atrium will increase again. This is C wave. After this, ejection will start here. Right ventricle will eject out the blood. Right ventricle will become small in size. Instead of such a big ventricle, it will become small in size. Ejection, blood ejected out. When the blood is ejected out, this tricuspid ring goes down. This becomes small. When this becomes small, the pressure here falls. This is X descent. Tricuspid ring pulled down during ventricular ejection. The venous return continues. Because of this venous return, V wave. And after that, this valve will open. So blood will move from here to here. Opening of the tricuspid valve. Blood goes from here to here. Pressure here falls again. So this is Y descent. This is V wave. V wave is because of the venous return and Y descent is because of opening of tricuspid valve. Okay. So, okay, it's very easy for me to tell all this, but it's really difficult to understand. You should have the idea of cardiac cycle. Only such type of thing can be understood. Okay, you have to pay attention repeatedly, then you can understand all this. So A wave is because of atrial contraction. This contraction, this is because of the bulging of the tricuspid valve. X descent, tricuspid ring pull down. V wave, venous return. And Y because of the opening of the tricuspid valve. This valve open, blood goes from here to here. Okay, so these are the 5 waves. 3 positive waves, A, C and V, and 2 negative descents, X and Y descent. A, C, X, V, Y. So question here is related to C wave. This question was asked last year also. Is okay? Students find such type of questions difficult, but just see here, C wave in JVP is because of this thing. This is C wave. Atrial contraction, A wave. Venous return, V wave. Opening of tricuspid valve, Y descent. Y descent can explain this. This okay? So JVP and their causes. This okay? Other things, these concepts will be applied in medicine also. What is the cause of Canon C wave, tall A wave? Okay, all these are the part of medicine. In physiology, what are the waves and what is the cause? In which part of the cardiac cycle it lies? Then in a disease state, how they are modified? Again, this will come in medicine. Right? Okay. See the next question. Again, fourth heart sound is because of what? First and second we know. First heart sound is because of mitral and tricuspid valve closure. Second is because of aortic and pulmonary valve closure. First and second we know. Okay. Third and fourth. Third is because of first rapid filling. First rapid filling is third sound and second rapid filling is fourth sound. This is first sound. Aortic and pulmonary valve closure, this is second sound. This is the cause of first sound. Okay, this is the cause of second sound. This is the cause of S3 and this is the cause of S4. Clear? These two are valve closure sounds and these are because of filling of the ventricle. When blood flows from here to here. First rapid filling. Okay, this valve opens and blood goes from here to here at a high speed. And that high velocity will lead to turbulence. These are not valve closure or valve opening sounds. No, this is because of turbulence. High speed turbulence. This is third heart sound. And fourth, when this chamber contracts, again blood flows. This is second rapid filling. This is fourth heart sound. First rapid filling is passive. Valve opens, rapid filling, passive. Second is because of atrial contraction. Atrial contraction will lead to rapid filling again. This is fourth heart sound. Atrial contraction will not produce sound. When blood will flow, that will lead to turbulence, that will lead to sound. Okay. So third and fourth. Third is because of first rapid filling and fourth is because of second rapid filling. Okay. Fourth heart sound is because of second rapid filling. When atrium contracts, then we have the fourth heart sound. Is okay? Third and fourth, they are not audible. They can be recorded by phonocardiogram, but third and fourth, they are not audible. First and second, they are audible. Okay, when these sounds become audible, it may be pathological. Is okay? Yeah, D is the answer. Okay, JVP, heart sound. Okay, in cardiovascular system, just mug it up. Even if you don't remember, don't understand, just mug it up. Okay, the cause of waves in JVP, 5 waves, their cause. And similarly, 4 sounds and their cause. Is okay? Okay, see this question. PR interval represents the conduction of impulse through what? PR interval. Impulse is conducted through what? Just see. PR interval is from this point up to this point. Ideally, we should call it as PQ interval, but no, we call it as PR interval. Is okay? So, this represents what? This is representing what? Atrial depolarization. Okay? Atrial depolarization. And this thing represents ventricular depolarization, and this is ventricular repolarization. Okay, this is atrial depolarization. This is ventricular depolarization, and this is ventricular repolarization. If I draw it like this, this is atrial depolarization, this is atrial repolarization, which we don't record usually. This is ventricular depolarization, this is ventricular repolarization. Atrial repolarization is not recorded. It's a weak current. It is concealed behind this ventricular depolarization. So atrial depolarization is behind this. So here atrium is depolarized, here atrium recovered. So roughly this is atrial systole. This is ventricular depolarization, ventricular repolarization. So this is ventricular systole. Atrial action potential will lead to atrial systole. Ventricular action potential will lead to ventricular systole. So ventricular systole starts here. Atrial systole starts here. This okay? So obviously, if this is the heart, from SA node, it will go to AV node, bundle of S, then branches. Atrium depolarized, then ventricle depolarized. So PR interval, this interval represents what? This interval. That the before this is atrial depolarization, ventricular depolarization. It means that the impulse is conducted through AV node. Okay, conduction through AV node. B is the answer here. This is done. AV nodal conduction. Prolongation of the PR. If this PR interval, this thing is prolonged, say it becomes like this. Prolongation of the PR. What is this? Heart block. It simply means that AV node is defective. First degree heart block. Okay. So PR interval represents the conduction of impulse through AV node. AV conduction. Is it done? See the next question. If the radius of an arteriole is doubled, blood flow will become, what's the answer? "16 times the flow." Just see, this is a pipe. If the diameter of this pipe becomes double diameter, the flow will become 16 times. 16 times raised to the power 4. Flow is proportional to radius raised to the power 4. So 2 into 2 into 2 into 2, 16 times. This is known as Poise Village Law. Poise Village Law. Poise Village formula. Poise Village Law or Poise Village formula. Okay, raised to the power 4. Sometimes this is also known as fourth power law. Fourth power law. Is okay? 16 times. Okay, it means that if there is slight vasodilatation, the flow will increase tremendously. And slight vasoconstriction, the flow will decrease tremendously. This okay? So this is fourth power law or Poise Village law. R raised to the power 4. Okay, flow depends on delta P. It depends on radius also, raised to the power 4. Inversely related to viscosity and length. And pi by 8 is the proportionality constant. So this law I have explained in my classes. This is Poise Village law, fourth power law. The main point here is R raised to the power 4, fourth power law. So if radius becomes double, the flow will become 16 times. 2 into 2 into 2 into 2. Is okay? Okay. Just see the next question. Stage 2 in the following figure is because of what? What is this? This is the action potential of a ventricular cell. Action potential of skeletal muscle is like this. Action potential of the cardiac tissue is like this. In the skeletal muscle or in a nerve fiber, it is something like that. Okay, depolarization, repolarization. But in heart we have depolarization, repolarization, but we have a plateau also. This is right. Here in the skeletal muscle, this is because of sodium. I have already explained that. Okay, just see. In skeletal muscle, this is because of sodium and this is because of potassium. In heart, this is because of sodium, this is because of potassium. Fine. It has a plateau also, and plateau is because of calcium influx. Calcium influx. Simple. Sodium channel opens fast, fast depolarization. Calcium slow. Okay, so slowly that depolarization is maintained. Calcium influx continues for much more duration of time. So this is because of calcium. Answer is very clear cut here. Answer is B. B is the answer here. Is okay? Answer is B. Right? Staging also you see it. This is stage 0. This is 1. This is 2. This is 3. This is 4. Okay, standard nomenclature. Stage 0. Stage 0 is because of sodium. Stage 3 is because of potassium. Stage 2 is because of calcium. Stage 1 is because of stage 1. Stage 1 is because of this. If you can remember, this is responsible for stage 1. Is okay? If you see this is because of sodium influx, this is calcium, this is potassium, and this stage 1 is because of ITO. Okay, ITO channel. Okay, if you can remember, if you can mug up, stage 1 is because of ITO channel. Is it clear? So this will become a difficult question. Why do we have stage 1? Why small recovery, full recovery? Okay, this small recovery is because of, okay, recovery is always because of potassium. So this is because of potassium. But why not full? Because it is a special variety of potassium channel. Okay, ITO channel. Okay, transiently outward current. So stage 1 difficult question, but stage 2 is easy. Is okay? ITO is stage 1, not plateau. Stage 2 is because of calcium. Is right? See the next question. Volume of air present in lung after normal expiration can be described as, okay, after normal expiration. What should be the answer? What should be the answer here? Just see this. Inspiration, expiration, inspiration, expiration, inspiration, expiration, deep inspiration, again normal, deep expiration. So this is tidal volume, this is inspiratory reserve volume, this is expiratory reserve volume, and this is a residual volume. 4 volumes. Tidal volume, normal in out, over and above what you can inspire, inspiratory reserve. Over and above that what you can expire, expiratory reserve volume, and the volume which you can never expire, residual volume. 4 volumes. And then we have 4 capacities also. What is this? Total lung capacity, TLC, total lung capacity. What is this top 3? Vital capacity, VC. What is this bottom 2? This is functional residual capacity, FRC. And what is this top 2? This is inspiratory capacity. 4 volumes and 4 capacities. Volume is individual volume and capacity is permutation and combination. Right? Okay. Okay, so this is tidal volume, inspiratory reserve volume, expiratory reserve volume and residual volume. All 4 combined. Total lung capacity. Top 3, vital capacity. Bottom 2, from here up to here. Functional residual capacity. The residual capacity for the functional purposes, normally which is residual. And this plus this, inspiratory capacity. This one, IC. So what is the question? Again read it carefully. Again read the question carefully. The volume of air present in lung after normal expiration. Okay, after normal expiration, here. The volume present in lung here. So what is this? FRC. So answer is this thing. Simple. FRC. Don't call it as FRV. Volume is individual volume. Ravi Sharma. FRC. Capacity is permutation and combination. Residual capacity for the functional purposes. Is okay? Residual volume is something which is present in lung after forceful expiration. We are talking about normal expiration. Done? You can see this diagram again. After normal expiration, the amount present is residual volume plus expiratory reserve volume. So this is functional residual capacity. This is done. Okay. See the next question. 42-year-old male has hemoglobin of 10. His oxygen carrying capacity is, how much is his oxygen carrying capacity? Hemoglobin is 10. 1 gram of hemoglobin, it can combine with 1.34 ml of oxygen. This is the conversion. Okay, 1 gram of hemoglobin can combine with 1.34 milliliter of oxygen. Therefore, 10 gram can combine with 13.4 ml of oxygen. So just you have to mug it up. 1 gram, 1.34. If hemoglobin is 10 milligram per dl, so it means what? So it simply means that 100 ml of blood, multiply it by, so it will become 13.4 ml per 100 ml of blood. Okay, you have to multiply it by 1.34. Normally, my hemoglobin is not 10. Normally, it is 15. So, if you will multiply this 1.34 into 15, normal, then it will roughly become equal to 20 ml per 100 ml, or roughly 19.4. So this is something which is normal. Normally my oxygen carrying capacity, if my hemoglobin is 15 gram per dl, not milligram, gram per dl. If my hemoglobin is 15 gram per dl, which is normal, then my oxygen carrying capacity will be 20 ml per 100 ml. This may be the answer in that case. But in this 42-year-old male, because hemoglobin is 10, so his oxygen carrying capacity will be definitely less than that. It will be 13.4. This is the answer in this case. So you have to simply multiply hemoglobin by 1.34. Okay, so answer will become this. Yeah, 1.34 into 10. Very clear. So this is the formula which is used. Done? Okay, let us see the next question. Carbon monoxide poisoning is. Carbon monoxide poisoning. What is this? There are 4 types of hypoxia: hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, histotoxic hypoxia. So carbon monoxide. Yes, what is that? Anemic hypoxia. This is carbon monoxide. Histotoxic hypoxia is cyanide. So don't be confused. Okay, many of the students will mark histotoxic, but no. Dr. Indu, no, it is not histotoxic. Okay, it is anemic. The main confusion. No, it is not histotoxic. Histotoxic is cyanide. Okay, it will do the poisoning of the cell, the oxygen transport chain. Okay, cyanide. Carbon monoxide will poison the hemoglobin. Okay, it will destroy the hemoglobin. Okay, hemoglobin will be destroyed, so that will be equivalent to anemia. So don't be confused with this question, very commonly asked question. He will not ask other types of hypoxia, he will ask carbon monoxide because he knows the confusion. Cyanide will destroy the mitochondria, oxygen transport chain at the cellular level. Histotoxic. Carbon monoxide destroys the hemoglobin. Okay, it will combine with hemoglobin, it will compete with oxygen. So instead of transporting oxygen, carbon monoxide will be transported. Is okay? So don't be confused. Okay? It is not methemoglobin, Ravi Sharma. When this combine, we call it as carboxyhemoglobin. Okay? Hb plus carbon monoxide. This is carboxy. Hb plus CO2. This is carbamino hemoglobin. And if it becomes ferric, Fe3 plus, in hemoglobin, iron is in the form of ferrous. When thus ferrous becomes ferric, when hemoglobin is oxidized, then it is meth. Okay, so methemoglobin is oxidized hemoglobin, right? Cyanide is histotoxic. See this question. At high altitude, oxygen tension in the blood becomes low. Okay. Hypoxic hypoxia, low oxygen tension. PaO2 will fall. This produces hyperventilation. Obviously, if you go to high altitude, low oxygen, so you will start gasping. You will hyperventilate. The low oxygen tension produces hyperventilation by activating what? When O2 will become low, you will hyperventilate. Why? This is through central chemoreceptor or peripheral chemoreceptor. Baroreceptor and J receptor, they are out of question. They are for BP regulation. This is something else. Oxygen will do hyperventilation through peripheral chemoreceptor. This is the answer. Carotid and aortic bodies, they are peripheral chemoreceptors. Is okay? Peripheral chemoreceptors. There is no scope of central chemoreceptors. Respiratory regulation is done through central chemoreceptors and peripheral chemoreceptors. Is okay? Peripheral chemoreceptors are present in carotid and aortic bodies. Central chemoreceptors, they will sense CO2 and H+. Central chemoreceptor can sense H+, CO2. CO2 will be converted into H+. Direct stimulus is H+, otherwise indirectly it can sense CO2, not oxygen. Oxygen will be sensed by entirely by peripheral chemoreceptors, carotid body and aortic body. This is done. Baroreceptors are for BP regulation. They are out of question. J receptors may be for J reflex and pulmonary chemoreflex. Oxygen acts entirely via peripheral chemoreceptors. Is okay? See the next question. All of the following will increase GFR except. Okay? Just see. This is the Bowman's capsule and this is the glomerular capillary bed. This is afferent arteriole. This is efferent arteriole. This is glomerular filtration. All will increase GFR except. Okay? Increased BP. Yes. When BP is increased, pressure here is increased, so more GFR. Yes. Afferent arteriolar dilatation. If this arteriole dilates, afferent, efferent, if this dilates, more flow, more pressure, more GFR. So this will also increase GFR. Efferent arteriolar constriction. If this constricts, so outflow is blocked. Inflow, outflow. If this constricts, outflow of the blood is blocked. More pressure here, more GFR. Okay. Here GFR increased, here increased, here increased. Hyperalbuminemia. Okay, GFR will fall. Except. This is the answer. Okay. If albumin here is increased, more protein, so that will pull the blood. That will pull the plasma in this direction. Okay, protein will pull. So that will pull, so GFR will fall. Okay, hyperalbuminemia, GFR will be reduced. Okay, Is it clear? Yeah, you are right. All of you are correct here. Is okay? Efferent arteriolar constriction increases GFR. If this is constricted, more pressure, this is outflow. So more pressure, GFR is increased. In the initial stage. In last part, when this is constricted more, then the total blood flow decreases, then ultimately GFR starts falling. That is true. But in the initial stage, which is physiological, the GFR is increased actually in the initial stages. Efferent constriction will do a biphasic response. First this is decreased, then ultimately it will be, first it will be increased, then ultimately it will be decreased. Okay, physiologically we consider the first response increase. Okay, hyperalbuminemia is the clear-cut answer here. If this choice is not available, then I can go for this also. Efferent constriction will do the this thing. I can choose efferent also if this choice is not available. Is okay? Yeah, Dr. Sadaf, it has a dual response. It's okay, but here I'll go for hyperalbuminemia. Very clear-cut answer. Okay. Next question. What is the main active part of countercurrent multiplier? Countercurrent multiplier. Dr. Shikhar Agarwal, which substance has the highest renal clearance? Renal clearance highest pAH. pAH renal clearance is 625. Inulin is 125. So pAH will have the highest renal clearance. Okay, just see this question. Main active part of countercurrent multiplier is, just see this. Countercurrent multiplier occurs in loop of Henle. This is the descending limb. This is the ascending limb of the loop of Henle. This is thin. This is thick. Thin descending limb. Thin ascending limb. Thick ascending limb. This thick ascending limb is the main part. In this thick ascending limb, the solutes are reabsorbed. And this reabsorption of solute from thick ascending limb, this is the main reason of countercurrent multiplier, main active portion. Others are passive. This is passive, this is passive. This is the main. And then we have the vasa recta. Vasa recta is for countercurrent exchanger. Vasa recta is also for countercurrent, but this is for countercurrent exchanger. And multiplier. Countercurrent multiplier in loop of Henle, countercurrent exchanger here. And here, this is active, grossly speaking, this is active, this is passive. Which part is main? Thick ascending limb is main. Okay? Thick ascending limb is main. So, which is the main active part of countercurrent multiplier? He is not talking about exchanger. Okay, so this is out of question. Which is the main part? Thick ascending limb, this is the main part. Is okay? Thick ascending limb. This is the main part. See the next question. Whose clearance is most near to GFR? Clearance of inulin is equal to GFR. Just remember this thing. Clearance of inulin is equal to 125 ml per minute is equal to GFR. And clearance of para amino hippuric acid is equal to 625 ml per minute is equal to renal plasma flow. Is okay? And creatinine clearance. Creatinine clearance, this is equal to 140 ml per minute. This is also roughly equal to GFR. Is okay? So PAH 625, inulin 125, creatinine 140. Clinically, we use creatinine clearance to assess the GFR. This is something which is used clinically. But physiologically, it is inulin which is most accurate. Inulin is something which is endogenous product. You have to inject it. Creatinine is inbuilt. It is present in the body. So just to assess it easily, in the clinical side, we use creatinine to assess that. But otherwise, inulin is a better indicator of GFR. So I think now you can answer. Whose clearance is most near to GFR? Which is most accurate? I think answer should be inulin. Inulin is 125. Creatinine is 140. Whose clearance is most near to GFR? Inulin. If inulin is not there in the choice, then I'll go for creatinine. Both are there, I'll go for inulin. Urea clearance is 50 to 70. PAH clearance is 625. This is equal to renal plasma flow. This is GFR, slightly more than GFR. This is GFR most accurate. And this may be some 50% of the GFR. Half of the urea is reabsorbed. Is okay? Yes, inulin is neither reabsorbed nor secreted. Is okay? See this question on acid-base balance, simple question. A patient has the following ABG findings. What are the findings? What are those findings? The pH is, how much is the pH? pH is 7.3. Arterial carbon dioxide 48 and bicarbonate 30 milliequivalent per liter. What is the diagnosis? Three things are given. One is pH, carbon dioxide, and other is bicarbonate. And you have to diagnose. I have repeatedly told you that in such type of questions, don't look at this carbon dioxide and bicarbonate. Don't look at that. Look at the pH first. pH is 7.3. Normal pH is 7.4. So pH is less than 7.4. So this is acidosis. This is not alkalosis. This is acidosis. Okay. So this is not possible, this is not possible. Two choices eliminated. It is acidosis. Now you have to establish the cause, whether it is respiratory or it is non-respiratory. It is some metabolic one. Who is the culprit? Who is the culprit? Who is the cause of that acidosis? This is something which you have to establish. If cause is carbon dioxide, it is respiratory. And if the cause is not carbon dioxide, it is bicarbonate, it is metabolic. Simple. Carbon dioxide is acidic in nature and bicarbonate is alkali. Simple way to remember. Normal carbon dioxide is 40. 7.4 normal, 40 normal carbon dioxide and 24 normal. These are the normal values. 40, 48, it is more carbon dioxide. So this is the culprit. So the answer is, culprit can be this also, culprit can be this also. If alkali is less, if less alkali is the culprit for acidosis, metabolic cause. But alkali is not low, alkali is high. So this is not the cause. This is the cause. More carbon dioxide can explain that acidosis. Cause is respiratory. If bicarbonate is less than 24, then cause may be metabolic. So cause here is respiratory. CO2 is high, therefore it is respiratory. Simple answer, simple explanation. If low bicarbonate explains that acidosis, then it is metabolic. Bicarbonate is high. Why? This is the renal compensation. It is high because kidney is trying to compensate that respiratory acidosis. It is respiratory acidosis. Simple. So I again repeat, don't look at other things first. Look at pH first and decide. pH 7.3, so acidosis. Who is the cause? More acid is the cause or less alkali is the cause? If more CO2 is the cause, respiratory. If less bicarbonate is the cause, metabolic. So this is not the cause, this is the cause. So respiratory. Is okay? Yeah, it is compensated by kidney. Increased bicarbonate represents the fact that it is compensated by kidney. Is okay? See the next question. Receptor for inverse stretch reflexes. Which is the receptor for inverse stretch reflex? Golgi tendon organ. This is the answer. Muscle spindle is the receptor for stretch reflex. And Golgi tendon organ is the receptor for inverse stretch reflex. Extrafusal fibers are just, they are the normal contracting muscle. Nuclear bag fiber is a type of muscle spindle. Muscle spindle has two types of fibers, nuclear bag and nuclear chain. Okay, so nuclear bag fiber is just a type of muscle spindle, you can say. Muscle spindle has two fibers, bag and chain. Both are for stretch reflex. Inverse stretch reflex, the receptor is inverse. Receptor is GTO. Okay. For stretch reflex, receptor is spindle, right? This was discussed in much detail in the classes. So many questions are asked from all this stretch reflex and inverse stretch reflex. So many questions. In the CNS, if you know it, you know it. If you don't know, you don't know. Okay? If you know the concept, then you know it. All will pass through dorsal column except. In the spinal cord, we have two systems. Let's see. If I see the spinal cord, dorsal horn, ventral horn, dorsal horn. So there are two systems. One is this dorsal column, and second is this anterolateral, this and this. So some sensations will go up through dorsal column, and some sensations will go up through anterolateral system. So what are those things which will go up through dorsal column? What are those? Fine touch, vibration, proprioception, localization, 2-point discrimination. They will all go through dorsal column. And through anterolateral, what are those things that will go? Pain and temperature. Crude touch also. Crude touch. Tickling and itch. Tickling and itch. Sexual sensation. Okay. So, dorsal column, these sensations. Anterolateral, these sensations. Just try to mug it up. Questions are regularly asked. Even last year question was asked from this. This is uncrossed. And this is a crossed system. This okay? Just try to remember, try to mug up. Somehow you try to remember this. Is okay? Dorsal column, anterolateral. Anterolateral is mainly for pain and temperature. All these are modifications of touch, you can say. Okay, touch and their brothers. And this is pain and temperature, different modalities. Is okay? So what is the question here? All will pass through dorsal column except proprioception, yes. Vibration, yes. Fine touch, yes. Pain, no. So this is the answer. Pain will go through anterolateral system. Okay, pain. Is okay? Simple, just you have to remember this. Ascending tract, sensory system. Sensory system will go up through two pathways. Dorsal column system, anterolateral system. Two pathways will go up for sensory. This will carry this thing and anterolateral will carry this thing. Right? Just see this. All of the following are functions of parathyroid hormone except. Okay. Yes, Dr. Prakash, you are right. touch, vibration, proprioception, 2-point dorsal column, pain, temperature, tickling, sexual sensation, anterolateral. Yes. Okay, see this question. All of the following are functions of parathyroid hormone except. Now, parathyroid hormone function, just see, this is intestine, this is kidney, and this is bone. Parathyroid will dissolve calcium and phosphate from here. Calcium, phosphate. Parathyroid will absorb calcium and phosphate from here. Parathyroid will reabsorb calcium, but try to remember, in the kidney it will excrete phosphate. It has a phosphaturic action. So this is the action of PTH. Calcium phosphate from intestine, okay, absorption, dissolution from bone, but in kidney, calcium reabsorption, phosphate excretion. It has a phosphaturic action. Is okay? So ultimately this will increase plasma calcium. Calcium from here, from here, from here. Phosphate. This phosphaturic action is stronger than this plus this. So phosphate falls. So plasma calcium is increased, plasma phosphate falls because of this very characteristic phosphaturic action. This is the action of PTH. Is okay? So see this. Calcium absorption from GIT, fine. Phosphate absorption from GIT, fine. Mobilization of calcium and phosphate from bones to blood, fine. Reabsorption of phosphate from kidney, no. Excretion of phosphate from kidney. This is the specific thing related to PTH. This is the answer. This is okay? So all of the following are functions of parathyroid hormone except this. This is not the function. PTH will excrete phosphate in kidney. This is okay? Just try to remember the actions of PTH. Don't forget this phosphaturic action. See the next question. All of the following are actions of cortisol except cortisol will lyse the protein, proteolytic action. Okay. Carbohydrate blood glucose increased, fine. And fat metabolism, it will lyse fat from here but accumulate fat here. So centripetal obesity. Is okay? It will retain sodium, sodium retention, so BP increased. And anti-inflammatory, fine. So this is fine, centripetal obesity, fine, increased blood glucose, fine, protein synthesis, no. It will lyse protein. Protein is lysed, abdomen is enlarged, and protein is lysed. That is why you will see stria, purple stria on the skin, stretch marks on the skin. Okay, protein is lysed. Protein is lysed in bones also. So weak bones. Okay, cortisol will make the bones weak and it will lead to the production of stria. Protein is not synthesized, protein is lysed. This is the answer. Is okay? Cushing syndrome. More cortisol will lead to Cushing syndrome, less cortisol, Addison's disease. So if cortisol will be more glucose, centripetal obesity, and stria, protein is lysed. Is okay? Yes, Steffi, you are right. Vitamin D will increase calcium and phosphate. What will vitamin D do? Vitamin D will absorb calcium and phosphate from here. This is the action of vitamin D. Calcium phosphate from here. And calcitonin will deposit calcium and phosphate here. This is calcitonin. Calcitonin mainly bones, vitamin D mainly intestine, PTH all three. So this green color is vitamin D. This is calcitonin, purple color. And red color is PTH. Is okay? Yeah, Dr. Prakash, Cushing syndrome. Yes, we have stria. Okay, stria is a feature, stria on the abdomen, stretch marks. This is the feature of Cushing syndrome. Why? Because protein is lysed on abdominal wall. Is okay? Which hormone will act through intranuclear receptor? Intranuclear, thyroid is the classical example. Thyroid is the classical example. Another example may be estrogen. Estrogen may be another example. Classical example is thyroid. Is okay? Cortisol is a steroid. Receptor lies in cytoplasm. This is cell membrane. This is also cell membrane. Growth hormone protein, receptor on cell membrane. Cortisol is a steroid hormone, cytoplasm. Epinephrine, cell membrane. So thyroid, okay, is the classical hormone whose receptor lies in the nucleus, straightway, intranuclear receptor. Is okay? See, classical example is thyroid. Thyroid is the classical example. Another common example may be estrogen. Is okay? Estrogen is a steroid, but its receptors have been found in the nucleus. See the next question. In the following diagram, the cells marked by arrow are. What are these cells? See this. This is JG apparatus. What are these cells? These cells. This is macula densa. Macula densa. And these cells are JG cells. Okay. And here at trijunction, there are some cells which are not depicted here. These cells are Lassus cells. Okay, macula densa, Lassus cell, and this entire thing, this is actually JG apparatus. Is okay? So these cells are JG cells. So these cells are JG cells. The JG cells will secrete renin. Renin is secreted by JG cells. Is okay? Yeah, you're right. These are JG cells. See the next question. Ghrelin is secreted from stomach. in the fasting state. Ghrelin is secreted from stomach in the fasting state. And this ghrelin will increase appetite. What will this do? This will increase hunger. After taking food, no ghrelin, okay, no hunger. So ghrelin is released from stomach in the fasting state. It suppresses appetite. Yeah, you're right. Not pancreas, no. It is released from stomach and it increases hunger because it is released in fasting state. Is okay? Okay. See the next question. Bile salts are maximally absorbed from where bile salts are reabsorbed. If you see the intestinal tract, duodenum, intestine, and this is colon. So bile salts are secreted from here in second part of the duodenum from bile. It will come from liver. They will emulsify the fat, digest it, absorb it, and from terminal part of the ileum, maximum bile salts are reabsorbed. Some may be reabsorbed from colon also, but maximum from terminal ileum. Again it will go to liver, again secreted in bile. So this is enterohepatic circulation. So the commonly asked question, from where these bile salts are reabsorbed? They are reabsorbed from terminal ileum. This is duodenum, jejunum, ileum. Small intestine, first part duodenum, then jejunum, then ileum. So last part of ileum, when the fat is digested and absorbed, when the job is done. Is okay? So jejunum, terminal ileum is the answer. Colon, small amount. It is there, but maximum absorption from terminal ileum. Is okay? Secreted in second part of the duodenum. Okay, it is coming from bile, major papilla. Okay, small intestine, it is reabsorbed maximum. Last part of ileum, terminal ileum. Is okay? Very common and simple question. Terminal ileum. Is okay? Okay. Let us stop here. We have discussed 25 questions. Any question you want to ask, you can ask. I'll take your questions. Any question you can write down. Otherwise, my best wishes for your exam, upcoming exam. Just few days left. Any question you want to ask, you can ask. I'll take your questions. Water absorption. There was one question asked like maximum water is absorbed from. If I ask you maximum water is absorbed from where? Jejunum. Okay. Absorption is the function of intestine, small intestine. So maximum water is absorbed from jejunum. Colon will absorb water, but it will absorb the final drop, the last few ml which are still remaining, which are not yet reabsorbed, they are reabsorbed from colon. Is okay? One question it was asked that maximum water is absorbed from. Answer will be jejunum. Maximum water. Don't say colon. Colon will absorb the last few ml. Whatever last small amount of water is there, okay, that will be absorbed from colon. But maximum water is absorbed from jejunum. Question number 3, what is that? Oh, question number 3 was left. Oh, it was missed. How come? Just see this. Calmodulin plays a role in the contraction of smooth muscle. In smooth muscle, like in the skeletal muscle, calcium, troponin C particularly, then tropomyosin, and then contraction. This is in skeletal and cardiac. But in smooth muscle, calcium will combine with calmodulin. And this will activate myosin light chain kinase, and which will lead to contraction. So in skeletal and cardiac, troponin C, tropomyosin, then contraction. But in smooth muscle, instead of troponin C, it is calmodulin. So calmodulin plays a role in smooth muscle. This question was missed, I think. It's okay. Maximum water in GIT absorbed from jejunum. Similarly, in kidney, maximum water is absorbed from PCT. Okay, PCT will absorb 60% of the water. This okay? Dr. Aber Raza, yeah, maximum water absorbed from PCT, 60%. Sure, then thank you very much. Vitamin B12 is also absorbed from terminal ileum. Iron is another in which question comes. Iron is absorbed from duodenum. Iron, if somebody asks for iron, it will be duodenum. Is okay? Okay, then thank you very much. All the best for your upcoming exam. Okay, my best wishes for that exam. And I hope good result will come. Okay, thank you very much.